Welcome to today's webinar, 3 pounds of matter injury. Now what? Long-term care considerations for medical legal cases involving traumatic brain injuries. This webinar is hosted by Medical and Life Care Consulting Services, case management and nurse consulting firm headquartered in Massachusetts. We're excited that you joined us for this presentation. My name is Gigi Liggins, and I'm the moderator for today's webinar. This webinar is anticipated to be about 60 minutes. We're excited to host today's webinar and look forward to an opportunity to partner with you. Kick us off, I'd like to introduce our presenter. Cynthia Borbo is president and founder of Medical and Life Care Consulting Services Incorporated, a registered nurse and certified rehabilitation nurse, case manager, nurse life care planner, and legal nurse consultant. She has worked as a nursing professional for 4 years and currently leads Medical and Life Care Consulting Services, a practice of professional nurse consultants and case managers who provide medical case management, medical legal services, including life care planning, and ancillary professional nurse consulting services. Cynthia founded Medical and Life Care Consulting Services in 2001 and is presently a member of the American Association of Nurse Life Care Planners and is a board member of the CNLCP Certification Board. She's also an active member of the Association of Rehabilitation Nurses and the Case Management Society of America. At this time, I'll pass it to you.
Good morning, everyone. Thank you for joining us today. This presentation's objectives are listed on the screen. Obviously, this is a very detailed and complex type of injury. The brain, we could spend weeks on just the brain anatomy and physiology. So this is just a brief overview of the important things that you need to keep in mind when you're caring for a patient or preparing a life care plan for someone with a brain injury. The objectives will be that you will understand the complex organ that is the brain. You will get a brief overview of the anatomy and physiology of the brain. You will understand the different types of brain injury, and we'll have a basic understanding of the long-term requirements for care and equipment for the various types of brain injury. Now, as we were preparing this presentation, the same thing happened as with spinal cord. We realized there is just too much information to I don't want to just skim over all of the details. So this is now going to be part one of a two-part presentation. The next presentation will be in September, and this will deal with the first parts of with all the objectives that are listed here, but the second part will deal with case scenarios of a life care plan for a mild brain injury and a life care plan for a complex, severe brain injury. So part one, here we go. What is the brain and what does it do? As you know, you can see from the screen, and you know from everything that we have learned as nurses and healthcare providers that it does many things, and it controls our whole body. So thought, memory, emotion, touch, motor skills, vision, breathing, temperature, hunger, to name a few. Next screen. Divisions of the central nervous system include the forebrain, the midbrain, the hindbrain, and the spinal cord. The forebrain is made up of the telencephalon, central hemisphere, cerebral cortex, rhinocephalon, basal ganglia, and the diencephalon, which is the epithalamus, the thalamus, the hypothalamus, and the subthalamus. The midbrain is made up of the corpora quadrigemina, the tegmentum, and the cerebral peduncles. The hindbrain is made up of the cerebellum, the pons, and the medulla oblongata, and then the fourth section is the spinal cord. Three major divisions of the brain are outlined here. The forebrain is formed by two central hemispheres that you can see in this picture. The midbrain, which includes the corpora quadrigemina, the tegmentum, and the cerebral punctacles, and the hindbrain, which includes the cerebellum, the pons, and the medulla oblongata. This is just a picture to show you that. So gray matter versus white matter. Gray matter in the brain refers to the darker outer portion of the brain. It is composed of neurons, somas, round central cell bodies, and the role is primarily responsible for processing and interpreting information. White matter describes the lighter intersection underneath. It's composed mostly of axons, the long stems that connects neurons together, and is wrapped in myelin, a protective coating. The role is to transmit that information to other parts of the nervous system. So the human brain enables individuals to reason, function intellectually, express personality and mood, and interact with the environment. It's a pinkish gray organ that weighs approximately 3 pounds in the average adult, and it has the consistency of tofu or custard. It's made up of about 60% fat and 40% water, protein, carbohydrates, and salts. It's not a muscle, but contains blood vessels and nerves, including neurons and glial cells. It receives approximately 15 to 20% of the total cardiac output. In the spinal cord, in regards to gray matter versus white matter, the order is reversed. The white matter is on the outside and the gray matter sits inside. The brain sends and receives chemical and electrical signals throughout the body. Different signals result in different processes, and then your brain interprets them and that results in an activity or an action or a feeling, etc. Messages can be stored in the brain or then can be relayed through the spine to different extremities. The central nervous system does this through neurons or nerve cells through the body. So here again are the main parts of the brain: the cerebrum, which is the front of the brain, the brain stem, which is the middle of the brain, and the cerebellum. The front of the brain is made up of gray matter, the cerebral cortex, and with white matter at its center. The cerebrum is the largest part of the brain, and it initiates and coordinates movement and regulates temperature. It also enables speech, judgment, thinking, reasoning, problem solving, emotions, and learning. It is also related to vision, hearing, touch, and other senses. The cerebral cortex is the outer gray matter covering the cerebrum. It has many folds and covers a large area due to this. It is also about half of the brain's weight. It is divided into two halves or hemispheres and covered with ridges, which are called gyri, and folds, sulci. The two halves join at a large sulcus called the interhemispheric fissure, the aka medial longitudinal fissure that is the one that runs from the front of the brain to the back. The right hemisphere controls the left side of the body, and the left controls the right side of the body. The two halves communicate through the corpus callosum in the center of the cerebrum. The brain stem, or middle of the brain, connects the cerebrum and the spinal cord. The brainstem includes the midbrain, the pons, and the medulla. The midbrain facilitates multiple functions such as hearing and movement to calculating responses and environmental changes. It enables movement and coordination and is important for ocular movement. The cerebellum, or little brain, is a fist-sized section of the brain that's located at the back of the head, below the temporal and occipital lobes, and above the brainstem. It has two hemispheres, like the cerebral cortex. Its job is to coordinate voluntary muscle movement and to maintain posture, balance, and equilibrium. New studies are being done to evaluate its role in thought, emotions, and social behavior as to its possible involvement in addiction, autism, and schizophrenia. Damage to the cerebellum is characterized by ipsilateral loss of equilibrium, balance, and motor coordination, so on the same side. The cerebellum has ipsilateral control, same side control of the body, in contrast to the cerebral cortex, which has contralateral control of the body, the opposite side. The pons, the second section, is the origin of four of the 12 cranial nerves 5, 6, 7, and 8, which enables tear production, chewing, blinking, focusing vision, balance, hearing, and coordinates eye and facial movement. It is the connection between the midbrain and the medulla. The pons is easily recognized by its bulging appearance below the midbrain and above the medulla oblongata. It transmits information from the cerebellum to the brainstem and relays motor information for the cerebral cortex to the contralateral cerebral hemisphere. It's important for the control of respiration rate and the relationship between inspiration and expiration. And the third area is the medulla oblongata, and the medulla is where the brain meets the spinal cord, and it's at the bottom of the brainstem, and it's essential to survive. It regulates heart rhythm, breathing, blood flow, and oxygen and carbon dioxide levels. It produces reflexive activities such as sneezing, vomiting, coughing, and swallowing. Reflex activities such as heart rate, respiration, blood pressure, coughing, sneezing, swallowing, and vomiting are controlled by this area. The nuclei of the cranial nerves, excuse me, 9 through 12 are located in this region. A major portion of the descending motor pathways cross to the contralateral side at the inferior medulla oblongata. And these are the basis for the contralateral control. Excuse me. So the spinal cord extends from the bottom of the medulla and through the large opening in the bottom of the skull. It's supported by the vertebrae, and it carries messages to and from the brain to the rest of the body. And we've thoroughly discussed spinal cord injuries and anatomy in previous webinars. So I want to refer you back to the website if you would like to see those. They are available. So an important thing that we consider when people are injured are their age and plasticity. And this is an important principle that states that the central nervous system can change. So children with brain damage may have functional areas that relocate to other areas of the brain when they have a brain injury. This ability, though, changes and decreases with age, which is why older patients tend not to recover from brain injuries as well as young patients. So here are the lobes of the brain: the frontal, temporal, parietal, and occipital lobes. And we're just going to talk about what the characteristics, what happens, what comes out of those areas. So the frontal lobe, and I did include these in the slides if you want to go to the next slide. The frontal lobe is the largest lobe and is located in the front of the head. You can take pictures of this if you want. These will give you little snapshots of each section of what they're responsible for. Personality characteristics, decision-making and movement, executive functioning, high-level cognitive functions such as problem-solving, language associated with ability to speak, recognition of smell, voluntary eye movements, and it also influences respiration, the GI tract, and blood pressure. The parietal lobe, or the middle part of the brain, helps us to identify objects and understand where our body is compared with the objects around us. It interprets pain and touch in the body. It interprets sensory input to define size, shape, weight, texture, consistency, which we take for granted because we're able to do that as we grow and develop. The Wernicke's area, which helps the brain understand spoken language, per Johns Hopkins, is in that area. The occipital lobe is the back part of the brain, and this is involved with vision, visual perception, and involuntary smooth eye movements. The temporal lobe, or the sides of the brain, controls short-term memory, speech, musical rhythm, smell recognition, and damage can cause fluent aphasia. Obviously, there is a lot of detail about all the different pieces of the brain. This is a cheap little shot of that. So additional structures deep within the brain include those that are listed on the screen. So the pituitary gland governs the functions of other glands in the body, and it regulates the flow of hormones from the thyroid, the adrenals, the ovaries, and the testicles. The hypothalamus is located right above the pituitary gland and sends chemical messages to control its function. It regulates body temperature, sleep patterns, controls hunger and thirst, and plays a role in some aspects of memory and emotion. The amygdala is located under each hemisphere. It regulates emotion and memory and is associated with the brain's reward system, so the stress and the fight or flight response when a threat is perceived. The hippocampus it's like a seahorse-shaped organ on the underside of each temporal lobe. It supports memory, learning, navigation, and perception of space. And it receives information for the cerebral cortex, and they're determining that it may play a role in Alzheimer's disease. The pineal gland is attached by a stalk to the top of the third ventricle. It responds to light and dark. It secretes melatonin, which helps regulate our circadian rhythm and the sleep-wake cycle. The ventricles and cerebrospinal fluid is produced, so the cerebral spinal fluid is produced by the ventricles, and it circulates in and around the ventricles and the spinal cord between the coverings of the brain, the meninges. It cushions the brain and spinal cord and washes out waste and delivers nutrients. And then the blood supply to the brain is through the vertebral arteries, and these follow the spinal column to the skull, where they join together at the brainstem and form the basilar arteries, which supplies blood to the rear portions of the brain. The internal carotid arteries branch into the skull and circulate blood to the front part of the brain. And the circle of Willis is a loop of blood vessels near the bottom of the brain that connects major arteries, circulates blood from the front of the brain to the back. And all of these names and areas and treatment, I'm sure, are very familiar to you, and I'm sure you remember that from school and education, if not in everyday practice for what you're doing now in the care of your patients or with life care plans. So the next section is cranial nerves, and this is a list of all the cranial nerves and what they do. So number 1 is the olfactory nerve, sense of smell. The optic nerve governs eyesight. The ocular motor nerve controls pupil response and other motions of the eye, and it branches out from the area where the midbrain meets the pons. The trochlear nerve, cranial nerve number 4, controls muscles in the eye. Cranial number 5, trigeminal nerve, is the largest with both sensory and motor function. It originates from the pons and conveys sensation from the scalp, teeth, jaw, sinuses, parts of the mouth, and face to the brain, and has function of chewing muscles and everything that's involved with that. Cranial nerve number 6 is the abducens nerve, and this controls some of the muscles of the eye. Cranial nerve number 7 is the facial nerve, and it supports facial movement, taste, glandular, and other functions. Cranial nerve number 8 is the vestibulocochlear nerve, and this controls balance and hearing. So when this is damaged, people have balance issues and they lose their hearing. Glossopharyngeal nerve affects taste, ear, throat movement, and controls many more functions. Cranial nerve number 10 is the vagus nerve, and this allows sensation around the ear, the digestive system, and it controls the motor activity in the heart, throat, and digestive system. Cranial nerve number 11 is the accessory nerve, and it affects specific muscles in the head, neck, and shoulder. Cranial nerve number 10 is the hypoglossal nerve, and this supplies motor activity to the tongue. And I wrote this all out for you so that you could see it. And if you want to take a picture of it or whatever, feel free to use it as a resource. So what is a traumatic brain injury? A traumatic brain injury can happen when sudden external physical assault damages the brain. But it's a really broad term, and it can be a vast array of injuries that happen to the brain. And the damage can be very focused and in one area of the brain, or it could be in multiple areas of the brain. And it can range from a mild concussion to a severe injury that results in coma or death. So there are two different types of TBIs. The first is a closed brain injury, and this happens when there's like a non-penetrating injury to the brain with no break in the skull. You know, a brick falls from the building and hits you in the head, but doesn't cause a break in your cranium. It can be also caused, like in a car accident, with a rapid forward and backward movement or shaking of the brain inside the bony skull that results in bruising and tearing of brain tissue and blood vessels. It's usually caused by car accidents, falls, and a multitude of reasons. Shaking a baby can also result in this type of injury, and we've all heard about shaking baby syndrome, unfortunately. Penetrating brain injuries are open head injuries, and that occurs when there's a break in the skull. Damage in both these areas can be with both these types can be very mild, or it could be very extreme, where you have brain shifts and hematomas that develop that cause pressure on other parts of the brain and really can cause some global damage. Diffuse axonal injury is something that I wanted to just talk about. This occurs when there's a shearing or tearing of the brain's long connecting fibers, the axons that happen when the brain is injured as it shifts and rotates inside of the skull. This usually causes coma and injury to many different parts of the brain. The changes in the brain are microscopic and may not be evident on CAT scan or MRI. So what happens when we have a brain injury? You know, there are so many areas that it affects. As we reviewed, the brain controls all aspects of the body's function. So it can result in cognitive issues, which can initially present as a coma, then confusion, shortened attention span, memory problems, amnesia, problem-solving deficits, problems with judgment, an inability to understand abstract concepts. So when people are not able to understand what you're explaining to them and you have to repeat it multiple times, loss of sense of time and space, decreased awareness of self and others, only able to accept one or two step commands can happen with cognitive deficits. And they can be very mild or they could be very severe. They could be temporary, and all of these can be temporary or they can be permanent. Motor deficits could be paralysis or weakness, spasticity, poor balance, decreased endurance, inability to plan motor movement, delays in getting started, tremors, swallowing problems, poor concentration. Perceptual or sensory deficits can be changes in hearing or vision or taste, smell, and touch, loss of sensation or heightened sensation in different parts of the body. It can be left or right-sided neglect, difficulty understanding where limbs are in relation to the body, vision problems, including double vision, lack of visual acuity, or limited range of motion. In regards to communication and language deficits, this can be difficulty speaking and understanding speech, which is aphasia, difficulty choosing the right words to say, difficulty reading, which is alexia, or difficulty writing, which is agraphia. Difficulty knowing how to perform certain very common actions that you've done many times, like brushing your teeth or combing your hair. That's apraxia. It can be slow, hesitant speech with decreased vocabulary, problems with forming sentences that make sense, problems identifying objects and their function, and problems with reading, writing, and ability to work with numbers. Functional deficits could be impaired ability to complete ADLs, IADLs, problems with organization, shopping or paying bills, an inability to drive a car or operate machinery. And it's all the things that we list in the FIM and FAM evaluations that are done in rehab. As far as social difficulties, obviously, if the part of the brain that controls your behavior is affected, you can have problems with social capacity, resulting in difficulty with having relationships, making and keeping friends, difficulty in understanding and responding to the nuances of social interaction. So you don't pick up on the cues that people are giving to you when they're facing you or talking to you or anything in communication. Regulatory disturbances can be severe fatigue, changes in your sleep pattern and eating habits, dizziness, headache, loss of bowel and bladder control. Personality or psychiatric changes, we see that a lot in patients with head injuries, and there can be apathy, not wanting to be involved with anything, decreased motivation, emotional liability, irritability, anxiety, and depression can cause disinhibition, temper flare-ups, aggression, cursing, lowered frustration tolerance, and inappropriate sexual behavior. Traumatic epilepsy can also occur. It can occur at the time of injury or within the first year, but it can also surface later. It can be both major or generalized seizures, and minor seizures or partial seizures, or it can be all of the above, depending on what has occurred in the brain and how much damage there is. Next slide. So coma is something that we deal with patients with severe traumatic brain injuries, obviously, and there's different ways to measure it. So coma is an altered state of consciousness that may be very deep, so no amount of stimulation can cause the patient to respond. It can also be a state of reduced consciousness so that the patient may move about or respond to pain. The depth of the coma and the length of time, depending on the location and the severity of the brain, it varies. And some recover well, and others have significant disabilities or don't recover from being in a coma. So ways to measure it can be the Glasgow Coma Scale, which is all these are very standard measurement tools, and it's a rating from 3 to 16. It evaluates eye-opening, verbal response, and motor response. A higher score shows a greater amount of consciousness and awareness. The Ranchos Los Amigos 10 level scale of cognitive functioning is how the patient responds to external stimuli and the environment. This consists of 10 different levels, and each patient will progress through the levels with progress and sometimes plateaus. Disability Rating Scale, the DRS, measures functional change during the course of recovery, rating the person's disability level from 1 to extreme. It assesses cognitive and physical function, impairment, disability, and handicap, and can track progress from coma to community. The FIM score is something that's used in rehab every day, and it measures a person's level of independence in activities of daily living. Then the scores range from 1, which is complete total dependence, or 7 to complete independence. The FAM was developed specifically for patients with brain injury and is a measure used along with the FIM. It is a 12 items that are scores, abilities from total help to complete independence on a variety of skills. And so the total FIM and FAM are 30 scores and are done periodically during rehabilitation. and we often use them in life care plans. So the reason for having this information gathered here for you is to talk about the long-term considerations with a life care plan. So we get attendees at our webinars for a variety of reasons, but this talk is focused on traumatic brain injury, and I'm making the assumption that most of you are attending know what a life care plan is. However, if you're attending just to learn more about the brain and injuries, that's all great too. But to define a life care plan, it's a plan of care for a patient that outlines the present and future treatment needs, both medical and non-medical, that will be needed for the remainder of their lives, and outlines the cost for that care or services and items. We do life care plans for a variety of reasons, but the most important and the basis for completing a plan is to outline a plan of care for that patient to follow throughout their lifetime. These can be used by families so that they have an understanding of what may be needed for their family member in the future, or even how often they should do things and what their care should be and what to watch out for. Obviously, they're used by insurance companies to set reserves, and in the medical-legal environment to determine future costs of care. Trust companies use them to identify what their clients will need to have provided by the trust in the future related to their injury. Now, life care plans are very specific to a patient. At no time should a life care plan be done which lists every possible intervention known to man under the diagnosis of traumatic brain injury. We have patients that trip and fall and hit their head and have severe aphasia or problems with coordination and dizziness. And that would be considered a mild head injury where they have a concussion. There's been no loss of consciousness. Or there's patients who have fallen off of buildings 20 feet and landed on their head and have a fractured skull, have multiple bleeds and hematomas, putting pressure on the brain. They have brain shifts. They have bruising of multiple areas of the brain. They have shearing, and you're amazed that they're alive. So it's hard to pinpoint specifically when you're not identifying what level of the diagnosis is. So while we're preparing this plan, I decided that I would give you a general understanding of what types of things are often seen in a brain injury life care plan. But this is just going to talk globally. It's not going to talk about the different levels of injury. In part 2, I'm going to do case studies for a mild brain injury life care plan and a complex brain injury life care plan. So the next sections are all the areas that we are working on or we utilize when we're caring for a patient with a brain injury and should be included in a life care plan. So again, the actual needs are determined by what the patient's problems are. If you've got a patient who had a brain injury and most of their symptoms are cognitive, they would obviously be going to speech therapy, social skills therapy, recreational therapy, some occupational therapy, but may not have issues with ambulation, mobility, balance, all those types of things. However, if you have a patient who, let's say, had a birth injury and has never been able to stand for any length of time, is unable to hold up their head, is unable to sit unattended, and doesn't bear weight, then you're going to have the whole range of all of these types of treatments and therapies that are available for them. And there are even more in addition to this. This is just the basic. So physical therapy, occupational therapy, speech and language therapy, aquatic therapy, hip therapy, auditory processing therapy, vision therapy, social skills group therapy. They can be focused on life skills therapy, vision rehabilitation, recreational therapy, adaptive sports programs, As children are in school or even young adults finishing college, tutoring can be needed, educational therapists can be needed, and also educational advocates for their IEP. If patients are a mild head injury, but have some physical impairments, drivers, regardless of if they have it or if it's a combination of problems, drivers evaluations can be done, drivers training classes can be done if they're deemed a potential ability to have the potential ability to drive. Vocational evaluations can be utilized if the patient has the ability to work because of if their problem is a very focused problem. So work and job coaching is available for people of all types of impairments. So that is also available. So it's not even a mildly cognitively impaired patient who just needs help finding a different type of job. Job coaching can be very intense and increase the patient's quality of life. Next slide. So future medical care depends on what problems they have from this. So obviously with a head injury, you're going to see a neurosurgeon or a neurologist or both, a physiatrist if there's any functional impairments or tone or spasm that's needed, orthopedist for the same reason. Mild head injuries can be just primarily problems resulting from the head injury and located and focused on cognition and vision and all those types of things. But a lot of head injuries are severe enough that they impair the function of another body part or another system, right? So there's all types of specialists. So internists are used more frequently, and then specialists. Rehabilitation nurse case managers are always recommended with a severe injury. Going through the process of recovering from a brain injury is a very stressful thing and frightening. So counseling is always included or usually included if a patient is willing when they're first injured and then later in life if these are ongoing permanent problems they have. Psychiatry is involved for medication management. A neuropsychologist is key for evaluating, what of the sequelae of the injury is impacting the patient the most and how to handle that. With additional injuries in the rest of the body, an audiologist, ear, nose, and throat, ophthalmology, neuro-ophthalmology, a dietitian, nutritionist, GI doctor, pulmonologist, cardiologist, urologist. We've had patients with severe head injuries that can have spinal cord symptoms. So they are quadriplegics with severe contractures due to spasm and tone. Cardiologists are involved, urologists, renal specialists, hematologists, oncologists for bleeding issues or clotting issues, vascular specialists, endocrinologists, pain management specialists, podiatrists, orthotists, to name a few. Again, this is just a small snapshot of the things that you would be using for different head injuries. And again, it could be any kind of lab work because damage to the brain can damage all of those ancillary systems that are very deep in the brain, the thalamus, the hypothalamus, all those kind of things, all those areas can be damaged, and which affects the rest of the body. So there could be 20 different labs that need to be done because of this type of damage. Basic ones are included here, and again, they're determined by the patient's status. So if there is a quadriparesis or a quadriplegia that results from the injury, then obviously that patient probably has a catheter. So urine testing, cystoscopy, urodynamic testing, bladder and kidney ultrasounds are done. EMGs, spine films, CT of the spine, MRI of the spine, bone density tests, X-ray of any joints in the body. But if it's a paraplegic with a head injury, it could be the bilateral shoulders, It could be any of the joints because immobility can result in the growth of, excuse me, heterotrophic ossification, which is an overgrowth of bone. So bone scans are done for that. If the patient is a child, then obviously developmental things need to be monitored. Scoliosis films, pelvic films, and those types of things. Respiratory wise, there are multiple things that can happen. People can have a decreased respiratory status. Maybe they're on a vent and have a trach because the damage to the brain affected their respiratory system. For people that are higher level, but they're now having periods of apnea, they'll do sleep studies to see if some of the sleep issues that are happening or cognition issues are because of lack of oxygen at night. That can be done in inpatient or home testing for central or obstructive sleep apnea, chest x-rays, pulmonary function tests, all types of testing can occur. As far as the GI tract, people can have hypomobility, they can have neurogenic bowels, and which result in constipation and complications that can result in death if you're not on top of them. So KUBs, abdominal CAT scans, colonoscopies, upper GIs are done. Brain MRIs, CAT scans, shuntograms for hydrocephalus and for shunts, when shunts are put in for fluid management. And then obviously EEGs for seizure disorders, which can be just a one-time EEG, or it can be a 24-hour, or sometimes, a 5-day hospital stay to evaluate the brain function because of significant ongoing life-threatening seizures. But again, this is just a snapshot. Here again, a snapshot of all the different types of durable medical equipment for the different systems. And again, it depends on the status of the patient. So I'll let you read all those. Those are all things you're all aware of and are just a snapshot of some of the things. Everything is individual to the specific patient in life care plans. So, you may have a patient that that had a head injury that resulted in pressure on the spinal cord, and they had some maybe a central cord syndrome or Brown-Sequard syndrome, where they have no motion of their upper arms. So different types of chairs are appropriate for different patients and different equipment. Basically, they could be total care, in which they're just lifted in and out, and a motorized chair is not appropriate for them. It would just be a regular manual custom wheelchair. You can go to the next page. I'm not going to read every one of these things because you're aware of all of them. This is stuff that we do all the time. Communication obviously is a big issue that happens with head injuries. And so there are people that have severe head injuries with spinal cord dysfunction and immobility, G-tubes, catheters, and they're not able to speak, but they're there. They have locked-in syndrome, and they're able to blink and respond. And so for those patients, communication devices are really their lifeline to the world and to being able to express themselves. And so something like a Dynavox with eye gaze works, and I've had a couple of patients that have had that. And it really is life-changing for them to be able to communicate effectively and to talk to their loved ones or say that they love them. Urinary, obvious stuff. Mobility equipment, bathing equipment, dressing equipment, very specific to each individual patient. Bedroom equipment. So obviously adjustable, fully electric adjustable beds for people who are very impaired. A monitor or a way for communication, environmental control units that are voice controlled if they're able to speak, just a control unit to maintain all their equipment and their to keep the temperature and control everything in their environment. over the bed table, transfer boards or Hoyer lifts, ceiling lifts are used. We use different cooking utensils for people with different issues. So a person with a head injury may have hemiparesis of one side, and so needs one-handed equipment. So all of those things are available. This is, again, very global. Keep going if you wouldn't mind. The next slide. Orthotics and prosthetics. So just because patients have a head injury, again, it affects the injuries that they sustain oftentimes affect different parts of their body. So equipment is needed for all of those things. If there was a severe deformity of the face, oftentimes, obviously surgery is done for that problem, but there are prosthetics for all different kinds of issues. And obviously there's people who have cancer, and so facial prosthetics are needed. Amputations of legs happen due to injuries, even with people with head injuries. So depending on their level of cognitive ability, prosthetics may be used in those situations. Special activity prosthesis can occur for people who have mild head injury and need things for activities of daily living, or they may have a special activity prosthesis like for running or swimming or something like that. AFOs, there's multiple types, KAFOs. Again, you may have a patient who ambulates with braces and with a walker with KAFOs with a head injury at the same time. Elbow and knee bracing for immobilization. So people with severe injuries can develop horrible contractures if they're not treated properly. So bracing is very important from day one. There are trunk braces and garments that are used in children who are developing, and there can be fractures that happen along with the head injury where a TLSO is needed. Dynamic or resting splints are often used for people with high tone or spasticity, and with this diagnosis, and also Medico-Legal boots to prevent contractures. So home care services depend on the situation, but these are a variety of the different types of services. So if they are able to be home, there are home health aides that can be awake aides, sleep aides, live-in aides. Nursing would be skilled nursing with an RN, LPN services, case management, management of the home. If the patient was living alone prior to this and is able to be in the home and maintained in the home, then a homemaker would be needed if there's no other family members there. Sometimes people's head injuries are mild enough that they are functioning, but they need supervision. So a companion can be a resource in that circumstance. Sometimes children with disabilities respond better with a nanny who's been trained versus a home health aide, which is very medically based. If that patient is living in their own home, it can no longer manage their home, so maintenance of the home has to happen, and that's, snow maintenance and yard maintenance, spring and fall cleaning, lawn mowing, and all those types of services. Facility care can be needed with people with severe brain injury. So obviously the area that you want them in, or our goal, is always to have them in the best situation possible. If they could live at home with 24-hour care, that would be great. But if that is not a possibility, then there are different services available. So there's transitional living that can happen after the acute rehabilitation stay to get them, if their brain injury is such that they're able and function, but just need some oversight. They can be home with home-based rehabilitation services, home with outpatient services, home and community-based, there's home and community-based Medicaid waiver programs that can help with all that. If they're not able to be sustained in the home, then obviously Group homes or residential homes would probably be the next, residential homes would be the next best scenario, where there's 4 or 5 people that are living in the home with similar disabilities, and someone to assist with their care and manage. Group homes are larger groups of people in a home, but again, allows a lot of independence and an improved quality of life. If they're not able to be managed in those settings, then a long-term care facility that has a brain injury or memory program would be appropriate. Another option is if they are high functioning, assisted living or supported living without services or with services of a home health aide, RN for medication oversight and maybe some medical treatment. Whether in the assisted living or in the group home and residential home, day programs with job coaching is available in those situations also. And oftentimes is great and gets people involved in life again. Next. Architectural modifications, again, depends on the level of injury and what you need. So there's a wide range of things here, from someone who's in a wheelchair and needing modifications to doorways and to hallways and an accessible bathroom off of their bedroom. Oftentimes people that have 24-hour care really need an addition or to take over part of the house where there's a bedroom, an accessible bathroom with a roll-in shower, and then a room for more equipment and the aids for 24-hour care monitoring. That is kind of a little bit away from the rest of the household, so it doesn't disturb the rest of the house. There are also rentals, addition rentals that you can rent by the month. So if you know someone who is waiting for to have modifications or have an addition put on, you can always rent an addition for a period of time that will attach to the house if the homeowner is willing. Next. There you go, more modifications. Not going to read them all, but we will get into this more in session 2. The next section is transportation. And again, this depends on the level of injury, but there can be just hand controls needed. It could be a van conversion that they recover enough cognitively, but they have other injuries that go with it. It can be arranging transportation to and from all appointments, in the short term or lifetime, which would mean identifying how many visits they have to go to throughout their lifetime, and then also adding in a weekly transport for shopping and other things they need to do for the home. Or transportation is another option. The next section is surgeries or invasive interventions, and there are a multitude of treatments that can be done regarding the patient depending on their level of injury. And so some of those are listed here, and they are backfills and pumps, Botox injections. They can be epidural or transforaminal or facet injections or blocks of any kind. Pain pumps are often used. Dorsal column stimulators are used. You may need patient with a severe injury may have a G-tube and a suprapubic catheter. I always put in an extra revision of each of those things in case they come out and the areas close up. And then with people with severe injuries, a severe brain injury can have severe contractures where tendon transfers or neurolysis surgery or cryoablation procedures are needed. And so those are some of the things that are needed for these patients. Next is hospitalizations, which you have to include. So mild injuries can result in seizures. And so in the event of seizures occurring, in the beginning, people are seen at the ER to make sure that there's nothing else that's going on. So ER visits can happen for a multitude of reasons, depending on the type of injury. We'll go into that with the next presentation. Short-term hospitalizations can occur 3 to 5 days, or extended hospitalizations 7 to 10 days. And these are often based on what the patient's history has been and how often that these have already occurred in their treatment up to date is a good prediction of the future. There's always a period of time for about 1.5 to 2 years after the patient is in the home requiring 24-hour care, where the bugs have to be worked out and we need to get the patient in a good, healthy state. And then once that happens, usually patients do very good in the home if they have good care. And then the last is just complications to consider, and those can be a multitude depending on the level of injury and what part of the body is affected. And these are just a few of those things that we will discuss in more detail with a specific diagnosed patient in the next presentation. And that's it for this week. A lot of information. Again, we could talk for a month on traumatic brain injury and not have enough time. So thank you for joining us today. Please watch for the next presentation, at which time I will present 2 separate life care plans with different levels of injury. Thank you.
Thank you, Cindy. Thank you so much for those who've taken the time to watch this presentation. 3 pounds of matter injured, now what? If you have a question about a case, remember our consultations are always complimentary. So you can visit us online at www.medicalandlifecare.com. Please note that we do provide comprehensive life care plans, life care plan projections and medical cost projections, a medical chart review and chronology, Medicare set-aside allocations, a focused estimate of care, and legal nurse consulting. Finally, for this presentation, if you'd be so kind to scan the QR code on the right-hand side of the screen and select this webinar, 3 pounds of matter injured, and give your feedback. You know, we produce and create this content based largely on what our attendees share with us. So please take some time to complete the survey. With that, stay tuned for the publishing of part 2. Again, thank you for taking the time to watch this presentation.